Administration. How is it typically given?
Well, the source says overwhelmingly oral. Tablets, capsules, sometimes syrups.
Right. And it lists common doses like 0.5 milligram, 1 milligram, 5 milligram tablets, plus liquid forms.
And it does mention parenteral routes, IV or IM, but notes they're pretty rare.
Yeah, reserved for specific cases.
Okay.
So after taking it orally, what's next? Absorption, I assume.
Correct. Absorption happens mainly high up in the small intestine, the proximal jejunum.
Ah, okay. And the source touches on bioavailability.
It does, and it's interesting. It says about 85% absorption from supplements, but only around 50% from food sources.
That's quite a difference. It really underscores why sometimes supplements are needed, or even those rarer parenteral routes if someone has severe malabsorption, right?
Exactly. Or if they simply can't take anything orally.
So once it's absorbed, it gets into the bloodstream. What happens then?
It travels bound to plasma proteins, mostly albumin, according to the source.
And crucially, the liver converts it. So it circulates not as folic acid itself, but as its active form, metyl tetrahydrofolate.
Right, so it's basically ready for action by the time it reaches the cells.
Which brings us to cellular uptake. How do cells grab it?
They use a specific transporter, the reduced folate carrier, or RFC.
Okay, gets it inside, and then...
Inside, it's converted again into various tetrahydrofolate THF derivatives, and this is where it does its main job.
Which is acting as a coenzyme, right, for DNA synthesis.
Precisely. DNA synthesis, repair, and also methylation reactions. It's fundamental.
So making the building blocks for DNA, purines and pyrimidines.
Which naturally means it's vital wherever cells are dividing rapidly.
Like in the bone marrow, producing red blood cells. Or during fetal development. Huge amounts of cell division there.
And that directly links to its main therapeutic uses, doesn't it?
Absolutely. Lack of folate leads to problems making DNA for red blood cells, causing megaloblastic anemia, those large, immature red cells.
So treatment aims to correct that anemia.
Yes, and also clear up the symptoms that go with it, like fatigue, pallor, maybe glossitis, that sore tongue, irritability sometimes too.
And we can't forget the preventative role, highlighted in the source, promoting normal neural tube development in the fetus.
Oh, definitely. Preventing conditions like spina bifida, that's a major public health intervention.
So if someone's on therapy, how do you know it's working? What does monitoring involve?
Well, clinically, you'd expect symptoms to improve. Mucosal changes might resolve.
And labs.
The source points to a rise in the reticulocyte, count the young red blood cells, usually within 5 to 7 days. That shows the bone marrow is responding.
Yeah, a good early sign.
Yeah. And then over time, you expect the hemoglobin and the MCV, the cell size, to normalize. Therapy usually needs to continue for at least 4 months to replenish stores properly.
Right. What about downsides? Are there adverse effects to worry about?
Generally, it's very well tolerated. The source mentions rare things like mild GI, upset, nausea, maybe some gas, a bitter taste.
Anything else?
At very high doses, potentially some CNS effects like irritability or sleep disturbances, but again, uncommon. Parenteral forms might cause local irritation, but that's rare too.
Okay. The flowchart also mentions special situations, populations who might need more.
Yes, definitely. Pregnancy and lactation are key. Standard advice is 400 to 800 micrograms daily.
Makes sense given the fetal development role.
Right. Also, people with malabsorption like celiac disease or inflammatory bowel disease might need higher doses, maybe even parenteral.
Any other groups?
Chronic hemolytic anemia, alcoholism, patients on dialysis, they all have increased requirements. And we need to consider drug interactions.
Yes, some medications can interfere with folate.
Exactly. The source lists phenytoin, methotrexate, trimethoprim, sulfasalazine as examples that can induce a deficiency.
Good to keep in mind. Now, this leads to what seems like the most critical warning in the flowchart: potential complications.
Yes, this is absolutely crucial. It's the risk of masking a vitamin B12 deficiency.
Can you unpack that? How does folic acid mask a B12 deficiency?
Well, both deficiencies can cause megaloblastic anemia. If you give folic acid, it can actually fix the anemia part, even if the underlying problem is B12 deficiency. The blood picture looks better.
Okay, so the anemia improves.
Yeah.
What's the danger?
The danger is that B12 deficiency also causes neurological damage. Folic acid does not fix that.
I see.
So if you treat with folate alone without realizing there's a B12 issue, the anemia might resolve, but the neurological problems can continue, potentially becoming irreversible, serious nerve damage.
That's a major pitfall. So
Yeah.
the absolute takeaway is
You must determine the underlying cause of the megaloblastic anemia before just starting folic acid. Check B12 status. Don't just treat the blood result without knowing why it's abnormal. Is it diet, absorption, medication, or B12?
Find the root cause. Don't let folate mask a B12 problem.
That's the critical message.
Okay, so we've